So we are continuing with the conversation that naturally follows coronary artery disease. And we're going to look at the clinical progression of ischemia. And we're going to kind of, after we look at that, we're going to note how differences in the size of the ischemic area affect the outcome. So if you recall, ischemia is a deficit in blood flow to an area. So diminished blood flow to an area, which would mean a decrease in oxygen and nutrient delivery to that tissue, and also an accumulation of waste, primarily carbon dioxide, at that tissue. So that's what ischemia means. So clinically, what's going to happen is at the tissue, in this case, we're looking at cardiac ischemia. So at the myocardium, we're going to see a decrease in oxygen, like I mentioned. And the one thing that we have to think about in regards to oxygen is that oxygen, the reason why oxygen is so important, is such an important nutrient, if you remember, is because without oxygen, we really are not going to efficiently make any ATP. And we're talking about the heart, which is already an incredibly metabolically active organ. So if oxygen deficit persists, that will shift the myocardium towards anaerobic metabolism, which of course you know is much less efficient. And in that process of shifting away from aerobic metabolism to anaerobic metabolism, we see an increase in lactic acid production, which would then decrease the pH of the area, which then also affects the contractility of the heart. So those are the chemical changes that are going to happen. How that's going to relate functionally is this decrease in oxygen, which shifts us to anaerobic metabolism, which decreases our ability to efficiently produce adequate amounts of ATP in order to maintain the job that the heart has to do. What that ultimately looks like in terms of functional changes is impaired contraction. So that would then lead to a stroke volume decrease because the heart is beating with both less force and also the velocity of contraction. So not quite as fast and also with less force. And that equates to less blood being ejected per beat, which is of course what stroke volume is. So we know that heart rate, so anytime cardiac output changes, which would happen in this case if stroke volume decreases because of this event, which is ischemic, driven by ischemia, if cardiac output is altered, in this case it would be diminished, there are all kinds of compensatory mechanisms to maintain cardiac output, as we talked about earlier. And so what we'll see the effects of compensation here, which would look like an increase in heart rate and potentially an increase in blood pressure. All of that's going to be controlled by reflex action, primarily the sympathetic nervous system, right? So in our lecture in class, we talked about the baroreceptors, and we talked about the fact that if blood pressure were to fall, that would immediately stimulate send a reflex, activate, I should say, a reflex, which would ultimately lead to an increase in heart rate and potentially an increase in blood pressure. That's all controlled. So how well you are able to respond to these functional changes and the effects of these reflexes are going to be determined most significantly by the actual amount of myocardium that's impaired. So the size of the area of ischemia, it will determine the outcome. So if it's just a small area of ischemia, you're going to see the effects of this reflex response due to the decreased stroke volume, which means, again, the baroreceptors detect that decrease in cardiac output, which will then send this reflex action ultimately to the brainstem, which will then send an outgoing message, activate the sympathetic nervous system, and we'll see an increase in heart rate and an increase in blood pressure. And in some cases, not all cases, but in some cases, this will also precipitate an angina attack. Angina pectoris angina is really a symptom of a larger problem. In this case, it's ischemic damage to the heart. So angina is kind of classically described as that's like substernal crushing pain Something like a friend of mine who had a major, had like 5 major occlusions and had significant ischemia, kind of presented in the classic way. And he described this pain that he felt as if he had his car parked on his chest. That's what they mean when they say crushing substernal chest pain. Now, that doesn't always happen. That helps when that happens because it really gets your attention, but it doesn't always happen. And angina is actually less likely in women than in men. Women don't oftentimes present in the classic form when they're having ischemic damage and potentially myocardial infarction. So at this point, they have not had a heart attack, right? We're still just talking about ischemia. So when somebody does have angina, however, that can actually, because it's painful, that can actually further stimulate the catecholamine release and or catecholamine sort of reaction, if you will. I guess release is a good term. And we will, which is oftentimes elicited by pain, and we'll see a further increase in heart rate and blood pressure. And so that really, the kind of key to this is it's a small enough area of the heart that the heart can still respond to this reflex action. And the response is an increase in heart rate and an increase in blood pressure. However, if it's a larger area of the heart that's been affected, so the heart's too severely damaged essentially to respond to reflex stimulation. It's not to say that the reflexes the reflex is not being initiated, right? The baroreceptors are still catching on to the fact that there's not as much pressure there, right? And they're still sending the message to the brain, and then the brain is generating this sort of outgoing response, but the heart's not able to respond to it because it's too severely damaged. So in this case, the cardiac output would continue to fall, and then we would ultimately see a decrease in arterial blood pressure. And then, of course, the blood is not going to be ejected from the heart. Instead, it's going to remain in the left ventricle and then continue to back up. So we see an increase in the pressure in the left heart chambers, starting with the ventricle, followed by the atria, and then the blood can even back up into the lung capillaries, and we'll see capillary wedge pressure as a result of that. So that's kind of, the short story in terms of how the area of ischemia will determine the outcome. All right, so if this ischemia persists, so if this blockade of oxygen delivery to the myocardium continues, then what we'll see ultimately is an infarction, which is prolonged ischemia, defined as prolonged ischemia of 35 to 40 minutes. And that tissue then becomes necrotic. The damage is irreversible to that region. We see local necrosis. We've talked about local necrosis already. You would see all of those sorts of responses that we talked about in the beginning. If you were to actually get some tissue, you'd see nuclear changes, right? The nucleus would shrink. It would become irregular. The enzymes, which is one of the ways we test to see if somebody's had a heart attack. You look for cardiac enzymes, and some are a little more specific, but there's, a whole study of an enzyme profile that you would run to look for enzymes that used to be inside the myocardial cells, the myocytes, and now they're outside of the cells and they're in the blood, right? That's indicative of cellular destruction. And then, of course, you'd see that inflammatory margin around the cells if you were to actually have a tissue sample there. So histologically, I was just kind of talking about that, the histological progression of a myocardial infarction, which again is another name for a heart attack. So the area will first, and this is pretty much across the board with necrotic tissue, the area will seem bruised, if you can actually see it. Within 24 hours, we'll see cellular edema and the inflammatory response. And then what will end up happening in this, as the inflammatory response gets going, by a couple of days, 2 to 3 days, enzymes are going to start to remove those necrotic cells. Remember, we talked about this before, right? This is inflammation. It's just or pardon me, this is necrosis. It's just, we're talking about it in a specific region. Because the heart is a hollow organ, and because the damage is in the wall of the heart, what will happen as the enzymes try to attempt to remove the necrotic cells, right? That's the job, one of the jobs of enzyme action or enzymatic action, is to go in there and get rid of stuff that's not supposed to be there, right? So enzymes are going to come in here to sort of tidy up the area, for lack of a better term. And during that time, because it's a hollow, the organ is hollow, and we're like, these enzymes are sort of eating away at this dead tissue in the wall. The wall can actually become very thin, and that can be pretty dangerous, right? So there's this window of time, a few days after a heart attack, where that person's in pretty serious jeopardy because of the fact that the wall, it's not like you can just give the heart a break, right? We can't say, oh, it's not going to beat for a while. That's not an option. That's what makes this a particularly challenging situation, because if the heart has to continue to meet the metabolic demands of the body, even though it's operating at this deficit, if you will. And so during this time, we worry about the fact that that wall is dangerously thin, and we can actually have a blowout in the wall, which I'll talk a little bit more about in a bit. But a couple weeks into this, we'll see the beginning of the scar formation. So you'll get some scar tissue in there. And, by 6 weeks or so, that scar is pretty well established, and the wall is pretty secure. Although, again, remember this conversation from our first lecture, that scar tissue is not cardiac muscle. Cardiac muscle does not regenerate. So this is a different tissue type, right? We've essentially got that collagen and, fibrous connective tissue. We've got a lot of tensile strength, but we don't have any functionality here. So that is a very important thing to remember. From this point forward, from the infarct on, for the rest of the life, that scar tissue will remain in the heart, and it will be non-functional tissue. So I think that's a significant piece of information that we have to have in the back of our mind in terms of the potential sequelae of a myocardial infarction. All right, so let's think about impairment, the degree of impairment following an infarct. So I think a lot of this is going to be kind of obvious, but the main factors that are going to affect the degree of cardiac impairment after an infarct are, first, what the size of the infarct was to begin with, right? If it's just a small area of myocardium, it's not likely going to be that significant. Not saying that it's insignificant, but it's most likely going to be not going to be insurmountable, I guess is a better way to say it. However, if it's a large percentage of the myocardium, that's going to be a different story. So, sort of the general rule of thumb is if more than 40% of the myocardium is damaged is gone as a result of infarct, that usually will lead to a condition called cardiogenic shock, which is the odds of coming out of cardiogenic shock are really not good at all. And we'll talk about it later. The next significant thing is, what part of the heart is actually affected? The anterior wall of the left ventricle is the most dangerous. And that's because the left ventricle is our big pumper, right? And it's responsible for, generating enough pressure to eject the blood to pump systemically. Also, the anterior wall of the left ventricle is perfused largely by the left anterior descending, one big main vessel, and of course there's branches off of that. So the left anterior wall is considered the most dangerous area for an infarct. And then the other question is, what's the rest of the tissue like? If somebody's had already multiple small heart attacks, right? The one small heart attack might not be a big deal, even two might not be a big deal, but if they've had multiple small heart attacks and now they have another one, with each infarct, you have more and more tissue that's non-functional. And so therefore, that's going to be a more serious situation. And then a very interesting thing to consider is collateral circulation. So collateral circulation is a way around ischemia, provided that the ischemia is sort of slow slowly developing. I don't know if that made a lot of sense, but essentially with collateral circulation, what we do is we encourage blood flow through vessels that might not normally be perfused. And what that can accomplish is it can accomplish, you can sort of bypass an area of problem by perfusing vessels that might not normally be perfused, like forcing open vessels, or in many cases we'll actually see it, and this is the situation if you have like coronary artery disease that's just slowly getting worse and worse and worse over a long period of time. It gives the body a long time to sort of develop another route, if you will, to that tissue. And that's kind of what's happening with collateral circulation. So, whether or not you're going to be able to utilize collateral circulation, my understanding of it is the most significant factor is if you have to have enough time to establish the collateral circulation. It won't work if it won't be an option if it's some sort of sudden blockage and consequent myocardial infarction. Sorry, I should have had this up as I was talking. So it's really the pressure differences that encourages the use of existing collateral. And in some cases, we can actually develop collaterals. And that, again, is most oftentimes going to be seen if there's been this sort of chronic mild ischemia over a period of time. So that person I was just referring to, the friend, it was a colleague actually of mine, who had 5 of his major coronary vessels greater than 75%. If I remember correctly, I think they were like 3 of the 5 were like over 90% occluded. And he had no symptoms of really any cardiovascular symptoms for a long time until he developed a pretty extreme case of angina. Like I just said, he sounded like the car parked on his chest. So luckily for him, his wife was also a medical person. She's a nurse. She recognized that he was having a significant episode of angina and encouraged him to have it checked out. Took him to the emergency room, actually, where then he was pretty much rushed into emergency surgery and bypassed all 5 of those lesions. And the part of the story that's interesting is that this guy was in pretty good shape, physical shape, and was, active and had a strong family history of cardiovascular disease. I believe his father died of a major heart attack like in his 40s. I believe his brother died of a major heart attack in his 40s. There was another male, I don't remember if it was another brother or I can't remember exactly, who died, of a major heart attack like in his 50s or something. And so that's about as strong of a family history as you're going to get. And the surgeon, when he came out of surgery, said that he'd never seen collaterals like he did in him, which makes sense because he had no real symptoms and really no deficit, wasn't short of breath, wasn't winded, was able to exercise. He was surfing and doing all sorts of things. And yet he had this he was getting very little blood to his myocardium, but he had all these collaterals that were very well established. So that's pretty interesting. So it's really a timing issue, I think, with the ability to utilize those collaterals. All right, so we've kind of talked about these reflex adjustments, but I guess I'll just go through them one more time with you. These reflex adjustments that help us to maintain cardiac output after a myocardial infarction. And then I want to talk about something that I haven't talked about, which is the vasovagal response, which is a paradoxical response. So the adjustments to help maintain cardiac output. So again, these are compensations. So of course it would be a stimulation of the heart rate and the force of contraction. That's of course driven by the by the sympathetic nervous system, right? That's a reflex response. We'll also see vasoconstriction that will increase blood pressure. This will very definitely include the veins, which will increase venous return and will stretch the myocardium. And as we know, the stretching of the myocardium, that's the Starling's forces, that's preload, which will then, of course, stimulate heart rate, a more forceful contraction. So those are reflex adjustments. We'll see some sodium and water retention also as a result of this, and this is mostly driven by the decrease in blood pressure, which will activate the renin-angiotensin-aldosterone system. So angiotensin will be the vasoconstriction part of this, and then the sodium and water retention is due to the presence of aldosterone and its action at the distal convoluted tubule, which is to reabsorb sodium and water in exchange for hydrogen and potassium primarily. But the key to this is the sodium and the water, because that will expand the blood volume. So we expand the blood volume, we vasoconstrict, including the veins, which will increase venous return, which will stretch the heart, which will increase the force of contraction. It's really fascinating, really, when you think about how incredibly well designed this system is to maintain cardiac output. Ventricular dilation, that's what I was just talking about. As long as it's not too crazy, this is going to work, right? If it persists, or if this continues to go on, you're going to pass sort of the ceiling, at which point compensation will no longer be possible, right? But we'll see ventricular dilation, we'll see ventricular hypertrophy. These are all compensation mechanisms to help to adjust or to maintain cardiac output. So the trigger for these responses, what do you think drives all of this? The thing that's driving all of this is, hopefully you're thinking, a decrease in cardiac output, because they've had a heart attack, right? They've had a heart attack, and they're not able to contract with as much force because part of the heart, the myocardium, is non-operational. And so that would lead to a decrease in cardiac output. So when the cardiac output goes down, all of these responses will be elicited, and provided everything is in working order, the cardiac output should be maintained, right, for a period of time. Now, sometimes when somebody has a major cardiac event, like a myocardial infarction, and sometimes it can be elicited by some other events as well, but let's just go with a myocardial infarction right now, because that's what we're talking about. Some people have what we would consider a paradoxical response. So it's an unexpected response. So in this case, what will happen is the vagus nerve will get stimulated. And the thought around this is, it's a couple things that could do it. One could be pain. Some people, when they experience pain or even kind of trauma, but pain is better in this case, that can, and I don't know why this is, but some people just seem to be wired this way, that will cause them, instead of having a sympathetic response, they'll have a parasympathetic response. And so what we'll see in this case is the stimulation of the parasympathetic ganglia in the myocardium, which of course is going to have the opposite effect of what we would want, because it's going to cause the heart rate to decrease, right? And we already have this issue of the decrease in cardiac output, which would lead to a decrease in blood pressure. There are also, I went digging around looking for some other explanations for this. And another explanation for what might elicit this vasovagal response is the location of the infarct. And one reference that I was reading was talking about if the infarct is in the interior of the heart, like near the septum, like at the lower portion of the heart and near the septum, that potentially can elicit the vasovagal response. So that's another thing to think about. All right, I'm going to end this video and pick up another one just to give you a break, because that one is kind of a lot to digest. So when we come back, we're going to talk about heart failure.